The topic of discussion for this time is we have got Achalasia Cardia, right? In this Achalasia Cardia, we'll be discussing about all these things. We'll be talking about these diagrams, and we'll be moving toward what? We'll be moving toward the content of Robbins, right? We'll be looking toward the content of Robbins, as you can see right here, and we will be relating whatever we have studied in our note. Okay, now without delay, let's begin the discussion. Okay, now what is this Achalasia Cardia? Okay, if you just recall the physiology, right? If you just recall the physiology, what you have is, in order for any food particle to pass, right? In order for any food particle to pass right down into the region of intestine or stomach, what we have is, we have the part behind it, right, should be contracted, right, and the part ahead of it should be dilated, so that the food particle will be pushed forward, right? This is the normal physiology. Now what happens in the case of Achalasia Cardia is, there will be what? There will be contraction. The contraction behind our food particle is normal, but here the region that need to be dilated will not be dilated. That means it will not be dilated. So okay, in the case right here in this diagram, you can see, right, now what are these plus neurons showing, and what are these negative neurons showing? This plus neuron are what? These are our what? Excitatory neuron, right? These are excitatory neuron, and this excitatory neuron are producing our acetylcholine. Now this acetylcholine will act at what? At the region behind our food particle, right? This excitatory neuron, they will do what? They will just compress this area, or they will contract this area. And this inhibitory neuron, what they need to do is, this our nitric oxide and VIP, what they need to do is, they need to act in this place and they need to dilate these areas. But here what is going on is, this inhibitory neuron are not functioning. Okay, as you can see right here, selective loss of inhibitory neuron will take place. If there will be loss of inhibitory neuron right here, what will happen? The muscle tone of this region will what? There will be there will be increase in muscle tone in this region. Why there will be increase in muscle tone? Increase in muscle tone means there will be contraction in this region. Since we have said there will not be any dilation, so there will be contraction or increase in muscle tone in this region. And this is what there is abnormality in what? Abnormality in motility, right? Abnormality in motility. So food particle will not able to pass down. Okay, now moving further, right, this happens because of two things. What are the two things? The first thing is, okay, it is classified into primary and secondary, right? Talking about the primary cause, is simple, right? What is the primary cause? The primary cause is there is loss of what? Inhibitory neuron, and such as there is there is loss of what? The action of nitric oxide. There is the loss in function of our dilators such as VIP, right? Vasoactive inhibitory polypeptide, right? And what are the secondary cause? The secondary cause are our Chagas disease, that is what? Chagas disease, right? And that is caused by varicella zoster virus. Okay, now talking about the clinical feature, what will happen if there will be not contraction in this area? If there will be no contraction in this area. As there will be no contraction in this area, what will happen is, if you look our this diagram here, you can see, right, this is the dilated portion. Why it is dilated portion? Because the food particles are not able to descend down properly. Why food particles are not able to descend down properly? Because here, if you can see in this area, what is this area? This is our what? Lower esophageal sphincter, right? In the area of lower esophageal sphincter, there is no what? There is no dilation, right? There is no dilation, or we can say there is what? There is excessive muscular tone in this area, right? In this area, because of which here the area is constricted, right? And here the area is constricted. As the area is constricted, there will be the difficulty in food material to pass by, and that is what? That is dysphagia, right? That is what we have, dysphagia. So dysphagia, you can see right here, dysphagia will happen difficulty in passage of food material, but it will mainly happen to liquids, not to solids. Why not to solids? Because it is believed that solid full particle will be more acted upon by gravity, right? It will be more acted by gravity, and as it will be acted by gravity, it will have a easy passes into our stomach. Okay, now as the person there will be difficulty in having food material, so the person is not likely to have adequate food amount, so there is chances of weight loss. Okay, now we talked about what we talked about clinical features, right? We talked about clinical features. Now moving forward, what we have is how we are going. Okay, it may also give rise to malignant condition, so it is pre-malignant condition. Now talking about such diagnosis, how we are going to diagnose this condition? Simply we are going to measure the pressure, and that technique is called manometry, right? We are going to measure the pressure in the region of lower esophageal sphincter. We are talking precisely about lower esophageal sphincter because it is the most common site of what? Most common site where achalasia cardia will take place. So now here as we're talking about diagnosis, we'll measure the pressure in the region of what? In the region of lower esophageal sphincter, right? There we'll find what? Increase in muscle tone in lower esophageal sphincter, or increase in pressure, right, in that region. Now another thing that we'll do for diagnosis is we'll have barium, right? Barium will be swallowed, and if we'll just observe the radiological image after swallowing barium, then we'll find that there will be broad beak appearance. Now what is this broad beak appearance? As you can see, what is this? This is our radiological picture. As you can see here, right here, if you see, this is the dilated part, right? As you just proceed forward, you will see the narrowing, right? You can see narrowing right here, and this narrowing is what? This narrowing is similar like bird's beak, right? Bird's beak. Now why it is narrowing here? It is narrowing because it is the site in which there is no what? There is no dilation, or there is high muscular tone, right? As we have mentioned, this is what? Lower esophageal sphincter, but this above one, they are dilated because of food material within them. Okay, now yes, we talked about what? We talked about broad beak appearance also. Now how for the management, what we can do is we'll provide various dilators that will just remove the constriction that we're talking till now. One of the important drug that we give is we give botulinum toxin. Now what is this botulinum toxin? It is inhibitor of it inhibits release of acetylcholine, right? Acetylcholine from preganglionic fiber. Now we know the function of acetylcholine is it causes contraction, right? It causes contraction. If this will be inhibited, then what will happen? Obviously there will be dilation. So botulinum toxin is the important drug that is prescribed in this case. We can also give calcium channel blocker that helps in dilation, right? And one of the most definitive treatment procedure is our myotomy. Now what is this myotomy? Myo means muscle, and tomy means what? Opening. Okay, now that means we are going to surgically open the constricted area. Now this myotomy is given a special name, that is Heller's myotomy, and this is the definitive treatment procedure. Now what can be the complication because of achalasia cardia? The complication that can be is there will be aspiration pneumonia. Why aspiration pneumonia? Because since there is constriction in lower esophageal sphincter, the food content can reflux, regurgitate, right? As they will reflux or regurgitate, because of regurgitation, what will happen? The food material can enter into the region of our lungs, right? As they will reach the region of our lungs, what will happen? There can be aspiration pneumonia, right? And another thing is it can result chronic achalasia cardia also, right? And this chronic achalasia cardia, what it will do is it can result into squamous cell carcinoma also, right? It can result into squamous cell carcinoma also, mainly in the region of lower part of esophagus. part of esophagus. Now just I would like to correlate this thing with the thing that we have already discussed about Barrett esophagus. If you remember Barrett esophagus, at the time, if Barrett esophagus was more complicated, then there would be the condition in which there it may give rise to what? Adenocarcinoma. And this Barrett esophagus, what was it? Was what? It was reflux disease, right? It was reflux disease. But here we are talking about Achalasia cardia, in which there can be regurgitation, and that regurgitation can what? The excessive of regurgitation can result into chronic Achalasia cardia, and that may be the cause of squamous cell carcinoma. So this was about what? This was about Achalasia cardia, right? We already discussed about this diagram. You can see dilation, widening of the esophagus, and here sphincter not working properly, that is lower esophageal sphincter, because of what? Because of loss in inhibitory neurons, right? Inhibitory neurons that are producing nitric oxide and our PIPs. Now another thing is, we talked about this radiological structure also, in which there was what? Our Bott's big appearance. Okay, now this is all about our content. Now let us move toward our Robbins content. Now, okay, Achalasia is characterized by triad of incomplete lower esophageal sphincter relaxation. Yes, there was no relaxation in lower esophageal sphincter region. That would cause increased lower esophageal sphincter tone. Yes, we talked about that. That may result of peristalsis of esophagus. Yes, opposite of peristalsis. Symptoms include dysphagia, that is difficulty in swallowing, difficulty in belching. Now what is this belching? Belching is a condition, the act by which we are going to expel the air from our stomach through the mouth because of excessive intake of air, right? There can be chest pain, and although there is some increased risk of esophageal cancer, that we said squamous cell carcinoma in lower part of esophagus. But okay, now we talked about what? Primary achalasia. Also we talked about secondary achalasia. Primary achalasia was because of what? Impairment in release of nitric oxide, because of degeneration of neuron that would provide nitric oxide, right? And talking about secondary achalasia, it was because of Chagas disease, in which there was the infection of Trypanosoma cruzi, right? Trypanosoma cruzi. Now yes, here we have got different clinical what manifestation, right? There is a lot of things mentioned right here, but the main thing that we need to that we are not meant to forget is the basic thing, right? Why the Achalasia cardia occurs? Because of what? Because of impairment in what? Our inhibitory, loss in function of inhibitory neurons, right? We need to know about the primary and secondary cause. What are the primary and secondary cause? Talking about clinical features, right? We need to know about dysphagia that may result to weight loss. Similarly, we need to know the way of diagnosing it, how we are going to treat it, right? We are not tend to forget this Heller's myotomy and the various complication, and these diagrams are so important, so keep these in mind. And that's all.